Good evening, everyone. It is with great excitement that we invite all of you to the Vein and Lymphatic University program tonight and webinar for our patients. I'd like to introduce my co-host, who's Gloria Salazar. She's the Vice Chair of Diversity and Health Equity at the Department of Radiology at University of North Carolina at Chapel Hill. On our panel, we have Anil Hingorani, who's clinical professor, Department of Surgery, NYU Grossman School of Medicine, who I've known for probably 30 years. Debbie Goodman is our clinical lead at the Vascular Associates at St. Peter's Health Partners here in upstate New York, and she runs our vein center. And we're pleased to have Linda Antonucci, who is board of directors here at the American Vein and Lymphatic Society, as well as president and CEO of Linda Antonucci Veins, LLC. This program is part of VLU, and of course, we owe great thanks to Lowell Kabnick, Leanne Eliso, and also Victor Kanata. I don't want to waste any more time, so I'm going to put this right over to my friend Anil.
So I want to thank you all for attending this conference. This is really what we were talking about even before the call started, that this is a really big advantage for patients, I think. And what we're going to be talking about is how to manage your expectations and how to have a successful visit when you're visiting your venous specialist. I have no disclosures. So most of the focus when you're going to go see your venous specialist is when you meet the physician. However, the expectations really are set up before you actually arrive at the facility, and your experience is really going to be dependent on 3 phases of your visit: before the visit, during the visit, and after. Your first contact, of course, will be on the phone or on the website when you're making the appointment. However, before you even set up your visit, I would make certain that you have certain tools ready before you even make your appointment. One of the things that you want to make certain that you have a good, successful visit is to bring your referral with you. It sounds very basic, but often without a referral, you don't really know the doctor doesn't know what you're there for. And if you don't know exactly what you're there for, what you're being referred to, that can create confusion and make things more difficult. On the other hand, if you bring in your referral, or at least the name of your referral and the reason why you're there, that puts the clinician in the right direction of what you're looking for. Before you go, make a list and prioritize your concerns. I want to talk about A, B, C, and D in that order so that you can hit your primary concerns and make certain that you focus on the things that you feel are really important. When you're making your appointment, certain patients may have mobility issues. And making certain that the facility is accessible to what you need is quite important before you even make your appointment. Certain patients may have problems with translation or need an interpreter. And many facilities will have interpreters or translators available. But call to make certain that they have an interpreter available for your specific needs. All along those lines, consider bringing a family member or friend to the doctor's visit. Why is that so important? Well, quite frankly, coming to the doctor's office can be quite stressful, and you may not remember everything that you may want to talk about, or having another person there, maybe another set of eyes and ears to make certain that you catch everything that the clinician says, or even afterwards, that you don't remember what the doctor said, or the nurse practitioner said, or whoever was taking care of you, and you can refer back to that family member or friend and ask them, what exactly was I supposed to do with this pill, or when exactly am I supposed to do this test, or when exactly am I supposed to come back? And having another set of eyes and ears to watch out for your concerns before, during, and after, and having that family member or friend come along with that whole process before, during, and after can really be a great crutch to help you along with this process and help ease some of your concerns. Bringing in prior pertinent test results can also be an important key component to making certain that the entire clinical team, including yourself, is up to date on what prior workup you may have had in the past, and helping point to what other tests need to be repeated or added to. Before you go, of course, always make certain that the office takes your insurance plan. Remember, just because they take Blue Cross Blue Shield doesn't mean that they take your specific plan. Blue Cross Blue Shield has many, many plans, and not all the offices take all of the plans for one particular insurance. So making certain that they take your insurance and your plan is important, especially nowadays, since there's a lot of variability in terms of which doctors take which plans, even which insurances. Depending on your insurance, you may have a copay, and be prepared for that. There shouldn't be any surprises. That's usually on the back of your card. If you're visiting a general practitioner, it'll say what your copay is. And for a specialist, it'll usually say what your copay is. Importantly, how long will your visit be? When you make your call to make your appointment or online, you should have an idea so that you're not rushed at the end saying, I got to go to my other doctor's appointment, or someone's here to pick me up, I got to run and I can't talk anymore. If you're prepared beforehand and give some extra time for your visit, for any testing that may need to be done, and any conclusion after your testing is done so you can discuss the results, that will make your expectations and make your visit much easier. When you go to the clinician's website, look for the goals, objectives, and vision of their particular practice to make certain that it aligns with what you're looking for. I can't tell you the number of times when patients have come into the office thinking that they were seeing A, B, and C doctor, and we weren't A, B, or C. And it creates a lot of confusion and frustration, not only because they're there and wasted all the time coming to our office, but now we have to refer them someplace else. Often these websites have some education materials that may help you before you come to the clinician's office and tell you about diseases that they treat. And quite frankly, some of them are actually very good. And I do think spending a little bit of time on the practice's website can be helpful. Some of these practices will have applications that you can download to your computer or your phone, and some of them are really, really good. You may want to test out that app before your doctor's visit to see if there are any questions. You can change your appointment. You can sometimes put down your copay or even afterwards. They're really, really useful. Some apps are really, really friendly and very easy to use. And finally, also looking for accreditation of the vascular lab or the outpatient laboratory can be very helpful, not because it's so important in and of itself, but it helps demonstrate that this particular office has gone the extra mile, spent the more time, money, and effort to go above and beyond what's required to making certain that there's patient safety and quality in everything that they do. When you arrive at the office, expect that the front desk is going to ask you some questions. They may make a copy or scan your insurance card and your identification. They may ask you some questions and ask you to fill out some forms, some general forms just to get some background history. You may be meeting a medical assistant shortly thereafter to get vitals. They may ask you some basic questions about your general history, your physical, your prior surgeries, past medical history. You may be meeting an RN, NP, or PA. And of course, you may be meeting your physician. They may order tests that we'll go into a little bit later with some of the other speakers. You'll be meeting your vascular technologist who may be doing some tests. And then in summary, you'll be meeting the physician, DO, or NP afterwards, who will go over your test results and make an assessment and plan based upon everything that you've been through. And they'll have access to just about everything that you've entered into the computer since you first visited the office and since you first stepped into the office. Before coming to the office, I would actually consider coming in 15 minutes early. There's always something that happens on the way to the office, quite frankly. There's always transportation problems. There's always a problem with the elevator. There's always some issues. And coming in a little bit early will just give you a little bit less stress in terms of just barely making your time or being late. Again, always bring your ID and your insurance card to every visit, quite frankly. Bring your list of your medications, your allergies, and your over-the-counter medications. This will help set up your doctor's visit and make things go much more smoothly. Rather than trying to remember or trying to call somebody or getting a list from the pharmacy and calling the pharmacy, just bring in your list. It's a lot easier. Even if you bring in the pills themselves, if you bring in all your pills and all of your over-the-counter medications, that's fine. If you have a long, detailed past medical history or past surgical history, I do find it helpful when patients have a list of them, either typed out or on their phone or on the portal or however they send it in. That's always helpful, especially if you have a long, complicated surgical or medical history. Having an advance directive can be an important component of your care. What do I mean by advance directive? If you have a healthcare proxy that you've designated in case you become incapacitated, not them saying that you should be or you will be, but having that explained to your clinician can be helpful at the outset, and at least you can scan it into the computer. Or if you have a living will, those are all fine to have in your doctor's offices, being a primary care or even a specialty office. Having the name and address of your pharmacy will also help the clinician at the end of your visit, because very often they have to send, let's say, a medication to your pharmacy. And if you have that readily available, you just give it, put it into the app, or give it to the clinician. They'll send your medications directly to your pharmacy, and it'll be ready by the time you get there. Of note, in New York State, we are no longer allowed, and we haven't been allowed for years, to give prescriptions by hand. We have to do them electronically, unless there's some overextending circumstance. We're required to send them electronically, and that adds some safety because I don't have to read my writing, because my writing is quite horrible anyways. When you actually meet the primary care, when you meet the venous tech specialist, it may be a physician, it might be an NP, it might be a PA. Again, you may be getting a duplex exam that day, but at the end, you should be able to get a final assessment and plan based upon the history, physical, and any exams that were performed that day. And at the end, you should get a specific follow-up of what the next steps will be. When you come to the office, especially if you're older, or even if you're not older, if you wear hearing aids or reading glasses, bring them with you. Always bring them with you, because you never know when you're going to have problems with reading. Bring a small notepad and a pen if you want to take notes or you have questions before or after. They just add as an added crutch to make certain that you get everything in that you want to mention. For virtual visits, there's slightly different aspects. There are some doctors that offer that. Again, I would download the app onto either your phone or your computer and test it before the visit. Often there are lots of problems with these apps, and it takes some getting used to each one because they're slightly different. Find a quiet, well-lit place for your initial visit, and make sure that the light source in the room is in front of you or off to the side, but not behind you. Otherwise, they won't be able to see what you're doing. Having someone else take care of young children or animals in another room can be helpful, because at least you won't have to be concerned about them and someone's watching them. It can be less distracting. If you have a wound that you need to bring your camera to, I would have an alternate light source like a flashlight or a pen light on hand so that you can spotlight that area when you bring your camera down to the area of interest that your doctor may want to see, or it's a rash or an ulcer or a wound or a varicose vein on your lower extremity or a spider vein or whatever. Expect that your virtual visit may last just as long as an in-person visit. So don't go skimping on time because it's a virtual visit. I find that a very common mistake, that patients think it's just going to be 15 minutes. It's not. Very often there's much more involved. It's sometimes not as efficient. And sometimes you have to spend some time trying to get all the pieces of information together. It's okay to have family members on your virtual visit also. Again, just like we talked about before, they can really help you through your whole process. However, if there are guests or family members who are not involved with the visit, do not have them in the room, and just have them in another room until your appointment is over. The co-pays for a virtual visit for most insurances is the same as it would be for an in-person visit. Many of these apps and many of these live streaming programs will take up a lot of power from your computer and electricity. Have your computer or your phone plugged in for the entire call. Close all the other applications and update your internet browser or program before you start, because you don't want to be updating in the middle of it because it won't work. During your visit, you should not feel rushed, and you should have the opportunity to ask questions before, during, and after the visit. You should have an opportunity for evaluation of the entire process. Some practices allow you to have an evaluation online. Some of them have a physical slip of a paper in a box, which is all fine. But more importantly, after the visit, you should be able to keep your doctor up to date of any changes, be it on the app, via phone call, via whatever circumstance you want to contact your doctor. You should have the opportunity to contact your doctor to see if things have changed, or you had problems getting that test that you were supposed to order, getting the medications. That can be especially important for medications that you may need urgently, such as patients with venous thrombosis. After the visit, you may be handed some patient education materials. Do read these materials. These can be quite helpful. Review your notes to make certain that your notes were that your questions were answered, and take advantage of the patient portals. Often, this will allow you to contact your team to see if you have any other questions or any other concerns that you thought of on the way home or after you got home. Venous disease is a lifelong disease. It can be chronic and it can be degenerative. It can affect your quality of life, especially with severe chronic venous disease. You can develop problems between scheduled visits. If you do develop problems between scheduled visits, contact your primary care doctor or your specialist and come in earlier. Venous disease is not a one and done disease, and these long-term relationships you need to think of these as a long-term relationship. If your team decides that you need a procedure, several questions are probably worth asking. Is there another way to treat my condition? What kind of procedure do I need exactly? What's the exact term, and what exactly will it do? What do I need to prepare for this procedure, and how long will it take? Does someone need to come with me after the procedure? Will I need anesthesia? How long will it take me to recover? What can I expect after my procedure? Will I need some special help at home? What do I need to do for the wound after the procedure? And what will happen if I wait for this procedure or don't have the procedure? Your medical team and you are on the same team. Be patient, but do ask questions if you have concerns. And at the end of the visit, confirm the next steps. Always keep the lines of communication open, and you'll have a successful outcome with your visit to seeing the venous specialist. Thank you. Looking forward to your questions.
Thank you very much. This was excellent. Actually, I want to just use this recording and show it to all my patients. Thank you so much. Very comprehensive. I don't see any questions at the moment. So thank you very much for this amazing review. Now I think what we should do while we don't have questions is to move and truly this is a multi-specialty or actually interdisciplinary team. So we're going to move on and have Debbie Goodman, our nurse, to actually give her perspective to our patients. Debbie?
Hi, thank you so much. I'm just going to start off by sharing my screen for my presentation. It just needs to be disabled so I can share. The PowerPoint, if you could disable it so I may share it.
While you guys get that going, I will mention that I've also known Debbie for a very long time, and she's been incredible and been on an evolution in my practice with me. from the time that we first started doing veins till today, where we've really grown it into a big practice. One option I have, Deb, is to see if I can't pull up your presentation on my screen. Okay. So give me 1 second and see if I can do that.
Debbie, it just came up saying you were the host.
Oh, excellent. Can you see me okay?
We can see you. We cannot see your slides. Maybe if you try sharing now.
Okay. Sorry about that.
And I couldn't agree more with Kathleen, like having this interprofessional team for a vein practice, it's amazing. The nurses, the technologists, all together, really, truly working together all the time. And that really towards patient-centered care. So, all right, Debbie, you're on.
Well, thank you. I just want to thank you for having me speak today. I want to just talk about a little bit what to expect when you come into your vein, appointments. Just to kind of start off, I have been a vascular nurse for about 15 years. I started as a baby bird fresh out of nursing school. And now I'm the RN clinical lead. Kind of what my job is just to oversee clinic operations to make sure that patients receive the appropriate care that they need, as well as the education that they need. For me, my perspective has been really awesome because I've been able to see us kind of evolve doing vein procedures. Originally, we only started doing just ablations, and now we're able to do a much more in-depth treatment for both superficial and deep vein issues. Recently, we just kind of started dabbling a little bit into research. So we have 2 venous research study projects that are going on that I'm super excited about. But from the patient's perspective, I want to make sure that you're comfortable when you come in to see us and that you feel like you've received appropriate education when you leave, so you know what to do. For us, when you come into your office visit, the way that we kind of gauge our patients is by a SEEP classification system. And for us, we start at C2, which is patients that have varicose veins, and we see patients all the way to C6, which are active venous ulcers, and anything in between. So really, if you have leg swelling, pigment changes, eczematous spots that are itchy, your legs feel kind of heavy at the end of the day, we're going to see those kind of patients. Patients that have more like spider veins, we would refer to plastic surgery because it's more like a superficial thing. In the office, when you come in, your provider is going to do an in-depth history and physical. The nurses are going to do a very in-detailed intake on you. So they're going to ask you your history and physical, and you may have updated it in your electronic medical record, but we're always going to double check that when you come in. We're also going to do your vital signs. For vascular surgery, we always check both arms because we like to compare it. Again, we talk about that SEEP classification. And then the VCSS score is a venous clinical severity score. And what that is a tool for us to measure your symptoms. So we'll know at the beginning of treatment and then after treatment if you've had marked improvement and where we need to work on. We also want to know—
Your slides are not moving, Debbie.
Oh, okay. Can you see it?
Yes.
We can see it. I think you just need, maybe you're passing it on your computer. Why don't you just put it on presentation mode on the bottom there of your PowerPoint, and then maybe that would make it go. It seems like it's pro.
Is it freezing on you? Is that a little better?
No, we still seeing the same slide. We're still seeing the first slide and not in presentation mode. Would you like to press on the presentation mode? Or maybe you can just hover over the slide that you're speaking to. Then we can see that.
Okay, I can do that.
For example, like slide 4, I think you're in slide 4 or 5, perhaps?
Yep, I'm on slide 4.
Okay, so why don't you press on over the slide 4?
Okay, hang on a minute.
With your mouse.
little different than yours.
Perhaps it is, yeah.
Okay. Let me just go to taskbars here.
Yeah, now you're in office visit. You're slide number 4 now.
Okay. I can just present it off of this way if it's easier for you to see it. That's fine.
Okay.
So back to the venous clinical severity score. So that helps us gauge, your symptoms. So it tells us some of the questions that we ask. Do you have pain? Is it occasional? Is it daily? Is it daily that you have to take medication for? Are you having swelling? Is it in the morning when you wake up in the morning, or is it at night after you've worked all day? We want to know, are you wearing your compression socks? We want to know if you've had improvement where we can actually gauge it and score it. As far as history of hypercoagulable state, this is more as we get towards like doing procedures. So we want to know if you've had history of blood clots, pulmonary embolisms, if anyone in your family has had this, any history of multiple miscarriages that were, not identified. Your provider will send you to see hematology if you're having had any history of this. We also want to do an in-depth medication review to make sure that you have all the appropriate stuff. As far as a vein history sheet, for us, we mail this out to our patients, and it really kind of helps us see what your symptoms are and how it affects your daily living. So do you have achy pain, heavy, tired, fatigued legs at the end of the day? Or is it that you're walking around and you're having cramping and you need to stop to take a rest? That's how your provider is going to gauge whether it's venous or arterial and what type of testing we need to do to make sure that you receive the appropriate care that you need. Your provider will take it to the next step. So at your initial visit, most insurance companies require you to have a 3-month trial of compression. My recommendation to you is to make sure that you're going to go to like a medical supply store so they properly fit your compression. They're going to measure you usually at the ankle, at the calf, and then at the knee level to make sure that it's appropriately fit to you. If not, if you go to like, Walmart and just pick up a pair, the problem is it may roll and dig into your leg and you're not getting the full effect of it. There's lots of options also if you go to a medical supply store. They actually have donning devices that will help you put on your socks. There's also options like Circade, where you see in the middle slide, where patients that have a hard time getting compression socks on, it's just a wraparound option. So it makes it just easier for you or your family to help you get them on. The last picture that you see is an Uniboot. That's a prescribed medication that we put on for patients that have active wounds. So what's next? You're at your office visit. You've had your compression. Where do we go from here? So do we need a lymphedema pump? So are you having chronic swelling that, is just not relieved by compression? So a picture on the top is a lady that has a LymphaPress pump on. And what they do is they actually come out to your house and they measure you. And they put this device on. If this is the problem with the leg swelling that is not venous in nature, you would wear this. Some will prescribe that to have it 1 to 2 times a day. And what it does is it helps get the fluid off your leg so you have relief of symptoms. The bottom picture is a picture of a patient that is undergoing Uniboot therapy or wound care. We also can refer patients out to wound care centers to get the most up-to-date and current, advanced technology in wound healing. We're going to also identify at that visit, what type of testing you're going to need. Just to kind of piggyback off of Dr. Hingorani is, you're going to need reflux studies. And when you come in for your study, it's going to be probably a good 45 minute to an hour study. So we always want to make sure that you plan appropriately and have appropriate childcare or whatever it is for your day to make sure that you have time to have that test done. The next picture where you see the picture of the legs, that is actually an arterial check to make sure that your problem is not arterial, because we're always going to treat the arterial issue first before we treat the venous disease. So if we go back to where we were talking about different modes of symptoms, that's how the provider is going to gauge. And these are some of our beautiful team members that help aid in that. Once you've gone in and you've talked to your provider, you've decided what your treatment plan is, next would be treatment for your veins. We always treat the lower part first. So we do a variety of different things. It can be ablation, phlebectomy, or sclerotherapy. We do it in the outpatient setting. So you would come into your procedure, and we have you bring a family member. We do offer a medication to kind of help relax you. You want to make sure that you have your questions with you. A lot of times patients will see their provider and forget things, and then when they go home, they kind of stew over their visit and say, oh my God, I forgot to ask these questions. So again, I do recommend writing these down so you have time with your surgeon prior to your procedure to make sure that you feel comfortable with everything going on. So you'll have time with your surgeon prior. You'll go in for your procedure. After your procedure, you're going to come back out. We're going to revisit. We're going to talk about all your post-procedure instructions. We want to make sure that you're comfortable. We do an assessment to make sure that you're not bleeding and you have understand all the education that we've given you in the aftercare. Other options is, so after we've treated the lower part of your legs, we have additional options for patients with venous disease. So we can do a venogram or an intravascular ultrasound. And what that is, that doesn't get done in the outpatient setting. It gets done in the cath lab. So they access into the upper part of your thigh. They'll put a catheter in, shoot images, and kind of see if you have any blockages. So if you have anything, if you see the dark type circles with the white inside of it, that is, the top pictures are the IVUS, and then the lower pictures are what venogram images look like. So that's what your doctor is seeing when they're working on you. And they can do stents, thrombectomy, or lysis if you have an acute DVT for treatment. And then after you have these procedures, we have you come back in, we do a new assessment, see where you're at, go back to that venous clinical severity tool scoring system to kind of see if you've had improvement and really where we need to take you next to make sure that you've had everything that you need as far as treatment, and then you're on the correct path. That's pretty much all I have. Does anybody have any questions?
This was great, Debbie. Thank you so much. Very comprehensive again. I do have a question that is often asked from patients, and I think there is this perception that the patient's going to go to our practice and it's going to be a one and done. And you have mentioned extensive, different possibilities for patients when they present to our clinic. Overall, what would you tell the audience now that is watching and maybe watch later? Like, what is the sort of the time frame that you give to patient, knowing that we don't know exactly what's happening in the first visit? Maybe we need additional imaging. But what is the time frame? You tell them, like, we may be able to treat you within 6 months, 1 year. So any thoughts on that?
Oh, of course. That's actually a fantastic question. So patients that have venous disease and need treatment, you're going to need several visits. You're going to start out with your initial, you're going to have a 3-month follow-up with your imaging. Then after your imaging, that's where you would track into whatever procedure modality is chosen in your care plan between you and your provider. After your procedure, you need another follow-up appointment. And it's kind of like I always say, like, my vein patients tend to be are kind of like our vascular family. They come back. We want to make sure that you're taken care of. And over time, really, you are the best driver for your body. And patients will be like, oh my God, I have a spot and I know it's there. Can you check it? And they'll come in, and sure enough, they've developed like an incompetent perforator that we need to take care of because they're going to have another active wound. So, it is kind of a long-term thing. With veins can regrow, unlike arteries. So it's definitely, a lifestyle modification. And the more you wear your compression socks, the less you're going to be friends with us.
That's a great way to put it, Debbie. Anil Hingorani, what do you think? What do you tell your patients? How often may they need to come back for, procedures?
So it really depends on their symptoms. Because we see a lot of patients with advanced chronic venous disease, a lot of our patients end up coming back fairly frequently because they have a lot of disease, unfortunately, and they often need a lot of procedures. But it really depends on their symptoms. So in general, as Debbie had mentioned, for the patients that need procedures, we tend to follow them more frequently. Unfortunately, I work here in South Brooklyn, so a lot of our patients, if you don't have a regular follow-up, they're not ever coming back ever again, even if they have an open ulcer that recurs. So we like to see our patients at least every 6 to 12 months, just to make sure that they're doing okay, just because a lot of our patients need that a little extra care just to make sure that they're doing okay, because otherwise they don't come in at all, even when there is a problem.
Great points. Just out of curiosity, Gloria, I know that you have a very intense practice with pelvic venous disease. How many of your patients have pelvic problems in addition to lower extremity problems?
That is a great question. And I think it goes along with, how many patients we have to find what Debbie described, like do a venography or do an IVUS. So for me personally, had been 20% initially, but now I work very closely with the gynecologist, as my practice also includes embolization of fibroids and other gynecological conditions. So I think I'm a little biased. My patient population is a little skewed that way, but I think generically speaking, I think we can expect, if we ask the questions, right, in our interview with the patients, I think we can fairly, safely say like about 20% of patients may need additional imaging, and then you may need to look for those pelvic varices depending on their symptoms.
Thank you. And Debbie, what's the best way to approach a patient about embarrassing, potentially embarrassing questions like varicose veins in the labia, those types of things? How do you approach that?
I always like to, first I always, talk about why we get varicose veins. So, every mammal that is upright and has to fight against gravity can get varicose veins. So when we do have patients that have that, I like to talk to them about, many women typically can have varicosities in the labial region, and I want them to feel comfortable going to their provider. Sometimes I've had patients where it's gone to the ultrasound and they skipped over the provider because they were nervous to talk about it until they got to the ultrasound component. And then it's, that's when they start talking about it. So I think that if you start at that initial visit and have that discussion, for the nurse to start that talk is helpful, because then the nurse can kind of be that, person to kind of bring it to the physician when the patient isn't maybe as comfortable.
Thank you for that. So then that segues beautifully into Linda. So Linda, can you tell us a little bit about ultrasound?
Okay. I need to be able to share my screen. So if I could become the host, please. And I'll just give you a little background while they're getting that set up. So I've been doing veins since 1987. And I was blessed to meet Dr. Lowell Kabnick right down at the bottom in center. And he took me under his wing, and that's all I can say. It's been such a blessing in my life. So I have to give him a shout out. And I'm sharing someone else's screen here, it looks like. Hold on. Okay. Move this banner down so it's not in my way. Don't you love how when we do this, we tell everyone exactly what we're doing while we're doing it? Okay, so can everyone see that? So is that okay? Can you see?
We can't see slides. We see something that says a leader in 2022.
Yeah, that came up, and I don't know whose screen that is. Let me stop sharing and let me see what's going on here. Does anyone else have a window open that?
There you go. You're good.
Okay. I guess it was my window and I don't even know what that was. Okay. Weird things computers do. So I'd like to thank you for having me, of course, and I'd like to thank the audience for being here. Really, this is really exciting, as everyone has mentioned. So I'm going to talk tonight about what to expect during your first ultrasound examination. Are my slides advancing before we even start? Okay.
Yeah.
Disclosures. So what is the role of the sonographer? That's what we have to ask ourselves. Why are we really here? Well, I think we're here to serve the patient and to serve the provider. And I think the most important thing, the main focus has to be on the patient. Now, when you have a sonographer that's in the vein world, let's just go back and leave this. We take an exam to, that's called the RPhS. And that's the only ultrasound credential for both providers and sonographers. So we have to kind of work as a team. Everybody's integrated here, and we want to think a little clinically. So I'm going to tell you what we do in our lab, and it's going to sound like maybe I'm echoing Anil and Debbie, but that's like Debbie said, sometimes the questions come out and the answers come out in the ultrasound room. So that's why we have to be a little clinical. So when you first arrive, we're going to ask you to change into a gown or into some nice fancy shorts, and we're going to put some booties on you. And we're going to say, please change and remain standing until we come back in the room. So why do we want you to stand? We want you to stand because then your veins are going to be dilated. And when we come in, any real points of interest will be jumping out at us. Okay. So then we're going to do a very detailed inspection. We're going to look at the front of your legs. We're going to look at the back of your legs. Then I may ask you to turn to your left so I can see the inside of your left leg and the outside of your right leg. Then I may ask you to turn to the other side so that I could see the inside of your right leg and the outside of your left leg. So what am I looking for? Well, I'm looking for any signs that may indicate you have a problem with your veins. I also want to know if your legs have, if there's any asymmetry. And what does that mean? That means that your legs are different sizes because you may have more swelling in one leg versus the other. So we want to look for symmetry. We're going to hone in on some clusters of varicose veins. We want to look for those big ropey, can you see my pointer? It's some big ropey varicose veins in the middle. And then we're going to look at your thigh and your calves, both inside and outside, for little spider veins. Other areas of significance, maybe you were nervous, you forgot to tell us you had a surgery, so we're going to look for scars, and we're going to look for small veins by your ankles that may give us a clue that a larger vein may be involved. Now, this sounds like a lot, but what we're doing is going to actually help us do a more focused ultrasound exam. We may even touch your legs. We're going to palpate bulges, look for soft or hard bumps. We also may feel for temperature changes. Maybe you have had phlebitis or, just some cellulitis or something. So we're also going to touch your legs. Then we're going to ask questions. We're going to encourage you to ask questions. Like Debbie said, you're probably nervous, but maybe by now, when we start asking questions and you get to know us, you may start to ask questions yourself. An educated patient really helps us do a better job. So we want you to ask questions. We want you to understand what we're doing. And some of the questions are going to be, first off, have you ever had any vein surgery or any treatment of any kind on your veins? Have you ever had a clot? Do you have pain in your legs, aching or heaviness? Do both your legs bother you or only one? If both, does one leg bother you more than the other? Do your legs bother you more at the beginning of the day or the end of the day? Do you have swelling that worsens at the end of the day? So you may see some similarities here, like time of day. We know that by the end of the day, when you're standing for a long period of time, that's when your veins are going to be dilated and your legs are going to start aching or feeling heavy at that point. And if you're female, we want to know, do your signs or symptoms worsen at different times of the month? Then we're going to ask you to lie down and we're going to perform something called the patency exam. And what that means is we're going to look for thrombus or clot in your veins. We're going to tilt the table. Don't worry, you're not going to slide off. We're just going to tilt it a little bit so the veins can become dependent and we can visualize them more easily. And we're going to look at the deep system and the superficial system for thrombus. The room's going to be warm because that's also going to help the veins dilate. If you get too warm, please let us know. We don't want you fainting when you stand up from heat exhaustion. And then we're going to explain to you what the purpose of the exam is while we're performing it. So we're going to be pressing on your deep veins and your superficial veins to look for clot. We're going to be assessing the valves in the superficial veins when you're standing to look for incompetence or insufficiency. When we lie you down and we compress, we're going to be pushing down on your leg with the transducer to get that vein to squish completely. So if you look down here, we have your artery and your vein and they're both open. And then we have in this slide here, you see the arteries open, but the vein is just a little straight line because it's squished. And that tells us there's no thrombus in the vein. We're going to do those compression maneuvers in your entire thigh and the entire medial aspect of your calf. So we know completely there's no thrombus. Then we're going to turn the color on and we're going to look at both your arteries and your veins. We're going to keep the arteries red and the veins blue. Then you might hear some sound because we're going to turn on what's called a Doppler. And it's going to make a wave sound. Unlike the arteries that will pulse and sound like a heartbeat, this is going to sound like a wave and that's the venous signal. So as it passes over the blood, it's going to make a wave. We may ask you to turn over into an alternate position, or we may even sit you up and dangle your legs over the edge of the bed if we can't see those tiny calf veins. Then we're going to do, once we've assessed the deep system and the superficial system for patency, to make sure there's no thrombus, we're going to ask you to stand if you are able. We may put you on a platform, a stool. I personally like to have the patient standing on the floor. I feel it's just safer for me to go down lower and have them standing on the floor. But many facilities may have platforms or stools. So be aware you might be asked. And if you can't stand on a platform or a stool, just let the sonographer know and they'll accommodate you. So what we're looking for now is functioning valves. If you look at the first little character here, you see the valve opens so the blood can go back to your heart. So when you're walking or when you're activating your muscles, the blood can go back to your heart. When you're standing still, the valves should close and create a nice seal here so you don't get any blood going backwards. When they're broken, the blood will go in two directions. So that's when we know you have a problem, when the valves are broken. So during this was that a question coming in? No? Okay. So during the insufficiency exam, we might use manual augmentation or we might use cuffs with an auto inflate. So we put these little cuffs around your calf and your foot and we will pump one up at a time and it'll pump and release. And that's how we test the valve. We pump, send the blood up and we wait and see if it comes back down. There are other maneuvers. I personally like peripheral augmentation release maneuver, but in Europe, the Piranha maneuver is very popular where they push and pull the patient and just sort of knock you off your balance so your muscles can contract and relax. And that's how they assess the veins. Some sonographers like to use the Valsalva maneuver. You take a deep breath in, you hold it, you bear down, and your diaphragm pushes on your vena cava, forcing the blood back down your legs and should cause the valve to close if it's normal or to swing open if it's broken. Another is just asking you to lift your foot and put it down. It's a dorsiflexion, and that also can send the blood propelling up and then coming back down. And that's how we're going to assess those valves while you're standing. We're going to look at your deep system at A, B, and C, and then we're going to look at your superficial system at all these points. And that would be your great saphenous vein, which runs down your leg in this direction. Then we're going to turn you around and look at your small saphenous vein, which runs down the back of your calf. You might see us using color as a screening tool. If we see flow reversal, which is a change of color, red in a vein, which we know red should be in the artery, then we know you have reflux. Then we have to measure it because your payers, your insurance companies, will want to see a duration. So then we're going to put that sound back on and we're going to measure the duration of the reflux. We're going to look at the antegrade flow. That's the normal direction. And then we're going to see that reversal of flow. And we're going to measure that. And we're going to also measure the diameter and depth of the vein while you're standing, outer wall to outer wall, so we can make sure that you get covered. And then we're going to put all this information on a mapping form so that the provider can see exactly what's going on. And they have sort of a pictorial, representation of this long, lengthy ultrasound report you see here on the right. And then all this information is going to be given to your provider, and they're going to set up a treatment plan based on their clinical findings and this ultrasound examination. And that's it. And then we're going to let you go home. This test does take about an hour. I will tell you that. Sometimes you might need to stop and take a rest. Please feel free to ask us and we will just let you sit down for a little bit and then we'll resume. Do we have any questions?
Thank you so much, Linda. This was amazing. We're almost towards the end of this webinar, but I have a quick question for you about any contraindications, any patient conditions that may prevent us from performing the complete evaluation of the reflux as you described it. I know there are not that many, but is there anything that the patient should know if we find something at the ultrasound, or if there's any patient condition that we may not be able to complete the whole ultrasound evaluation?
Yes. So if we find a thrombus in the supine position when they're lying down, we won't perform the standing with the augmentation. We do not do any augmentations when the patient's supine. We only look at resting signals and we do the compression maneuvers. So there's no chance of manipulating the limb and sending that thrombus north. So once that is, if we find something like that, it's immediately terminated. The balance of the test is canceled. Sometimes the patient isn't able to stand. Then we have to try to do it in reverse Trendelenburg. Sometimes they may have some kind of device on their limb that we can't remove, a brace of some sort. So there are those reasons. Those are the only that are coming to mind right now. I haven't been in a hospital setting in a long time, but I'm sure there are more in a hospital setting. But then again, I can't imagine too many reflux studies being performed in an inpatient setting.
You're absolutely right. I think these are the most likely conditions. Any other thoughts from our participants? Kathleen, any other question before we close?
No, the only thing that I would also add is that in upstate New York, where I live, it gets really cold. So if you have a thin, young woman, usually patient, and it's cold in the room, the ultrasound may not go as well just because the veins will contract.
Yeah, and we can warm the ultrasound gel, and we have space heaters in the room. So the overall office temperature is set, and we have a heater in the room. That's why I always tell the patient, if you get too warm, let me know, because we keep the rooms very warm.
That is a good one too, particularly this time of year in this country. But the last one would be the compression. A lot of patients are like, should I wear the compression stockings right before the ultrasound examination? And sometimes they're wearing for a long time. What do you recommend, Linda, in your experience?
Yeah, we tell them do not wear them the day, do not put them back on in the morning of the ultrasound. And if they tell me that their legs only hurt them by like 4 o'clock, then we try to book them at the end of the day also.
Yeah, that's how we get busy at the end of the day on the clinics. So start a little bit later, and then your patients are going to come later in the afternoon. Plus, many patients work, and it's probably an easier time as well for them to have their exams done and the complete evaluation. I think we're 5 minutes towards the end. If there are no pressing questions at this point, I would like to thank the leadership for VLU to allow this webinars to be directed to the patients. Particularly today, we had an amazing display of an interprofessional team with nurses, technologists, and physicians working together, and how important that is. In particular, I'd like to thank Kathleen Ozsvath for co-hosting this webinar and all the speakers today, and to Leanne for organizing all of us. I would like to also mention that in this initiative, we're going to be also doing the same webinar in Espanol, in Spanish, in 1 month from now, and this is going to be geared towards the Latino population that, also everybody has varicose veins. So we have to talk in Spanish a little bit for those patients. And that's going to take place next month on Wednesday, April the 26th. And so the idea is to basically have 4 major topics in both languages. So that's going to sort of conclude our first session of varicose veins, what to expect in the first visit. And then we will go to the second sort of theme and topic for this VLU series for patients, in which we are going to be on Wednesday, May 24th in English. We will be addressing a very important topic, venous disorders and disease in pregnant patients. So please be, aware these are going to come up in the next couple of months. So with that, I would like to thank everyone for your participation, and I'm looking forward to all of you for the next webinar in Spanish on Wednesday, April 26th. Have a great night.
Thank you so much.
Thank you. Thanks a lot. Great job. Thank you, everybody.
Thank you.
Thank you. Thank you. Bye-bye.
Bye.
Thank you all. Bye.
Bye, Lo.
Thank you.